Welcome back to another episode of School of Airway. Just a little brief introduction. Some of you residents who are real new had a 1 month of wellness, education, things that made you guys feel more comfortable, getting acclimated for your residency, location you're working at, right? You had all these things done. Then now you're working in the emergency room. Maybe you have not touched a patient in a long time, or taken something real seriously, like a rotation in the ICU, or the elective you wanted to get into, like the specialty you wanted to get into, emergency medicine. So now you're with the sick patients, and you're in some room with the red room, the trauma room, doing shadow shifts, or you're working a shift in CCT, critical care, trauma. All of a sudden, someone asks you, are you ready to intubate someone? And you're going to say, yes, no, I've never done it. The experience is an experience, but it's even better when you've been trained or had 2 weeks of intensive intubations of elective cases to give you a clue what you're looking at inside. Perhaps you're getting good teaching, maybe you're not. Or there's lack of teaching or great teaching. I'm not sure. It's very changed. It varies with the people you work with. Or we have a whole month with some attending to get taught with ER supervision, ED, from an ED perspective, how to intubate. But if not, there's some things you need to know. You always position the patient the best you can, if possible. If you can't, that's okay. Now, I've made a position them too much, but he'll live. He needs pre-oxygenation with nasal cannula and a face mask. But what was key to this lesson on this weekend is if he has no signs of trauma or suspected neck injury, you could turn them. But sometimes patients are turned on their own. And you're like, what's wrong? Maybe they had a bad stroke, they had bad arthritis. This neck will never move. Right? So you need to understand that sometimes the position of the patient is decided by the patient themselves, and you have to accommodate around the problem that they have. Bad kyphosis with bad arthritis, you will not undo that with rock, vecuronium, or succinylcholine. So you adapt. And the good thing about video laryngoscopy, you can adapt well, right? But there's certain basics, right? How to open the mouth. Chin push to open the mouth, or scissor technique. Not a love, hello, I care about you sign, right? Into the mouth and open, open, open. Now I'll give you a clue. When we gave sucks, because there was no contraindication, he has end-stage renal disease, but potassium was okay. He didn't have any weird myopathy, crush injury, burn, no allergies to sucks that we know of, right? No history of malignant hyperthermia, which of course people avoid all this question asking by just giving rock. Open the mouth, and I'm gonna tell you, I'll give you a clue. If the sucks works, look for fasciculations of the eyes, the face. Well, look, no spontaneous breathing. We were kind, we gave induction drugs. But we want to open the mouth. His neck is twisted this way. You adapt. I do not go midline. I do not hit the chest. I enter the right side, next to my thumb. Then I go midline. If I sweep enough, I want to have this intense white thing obstructing my view, which is usually the tongue. Because you guys don't like to do the sweep of the tongue, you just have this as an obstruction in passing your tube. Right? I use them as the same technique for DL blades, Mack or Miller, standard geometric, video laryngoscopy. My technique doesn't change. I use the blade to get the tongue structures out of the way so I can have a clear path for passing the tube. And then what you're really doing is prying open a space to allow my tube to go through, and I do a little lift. I don't do flexing the head forward, flexing the neck back. I just distract the jaw, distract your structures so I have more space to do this. Like a lot of you guys like to do whatever you guys want to do. Intubate with me, control the tube. And And when I say follow the curve of the blade, if the blade is curved, follow the path. Follow the path. You guys get stuck at the teeth because you guys are doing whatever you guys want to do. Follow the path of the curvature. Yeah, that means you guys never paid attention to the curvature of the laryngoscope, the blade that you're using. If it's glide scope and it's hyperangular, you never paid attention to the curve. You follow the curve, and then once you follow the path of the curve, once you're in, and you enter past the cuff, enter past the cords, pop the top. Now everyone thinks you're special in a bad way. They think they have to hold your hand. No, you pop the top. If you want to go a little deeper, as you go to the side and insert a little deeper, pop the top. It just makes it easier to enter more deeply the tube. Pop the top. Slide. Again, pop the top. Turn to the side. Slide deeper. Deep enough. Your thumb, because you're a primate, reminds you that you hold the ET tube now. Look what this hand can do now. I can inflate the cuff now. And if you really want to, have someone connect, bag. And if you want to, you can throw an OG tube now, because now you've distracted your jaw, and you have distraction of the tongue and the jaw. You can watch the OG tube get thrown in through the mouth. Not through the nose, but through the mouth. Right? Make sense? These are things for all you youngins. You young residents who kind of forgot what you're doing and never intubated before in the ED arena. Pay attention to what I did with my hands. Pay attention to what I said, and rehearse this in your mind next time you watch someone intubate. Understood? Understood.